Everything said on this podcast is entirely for entertainment purposes only. This is satirical and should not be considered clinical advice. In any situation, please use your own clinical judgment, using your own knowledge, expertise, and research. Consult with your local eye department if you're unsure, and always act in the best interest of the patient. Do not listen to the things that we say and take it seriously.
Hey guys, welcome to another episode of the Glasses Half Full podcast. Thanks for joining us. Last episode, we were explaining more common conditions and talking to each other how we would explain that to patients, and we learned a little bit how we would differ and learned a little bit from each other. Today, we're going to be doing much of the same, but with more uncommon conditions. These ones have a little bit more to them. It doesn't necessarily mean we're going to explain a little bit more to the patients, but hopefully we can see if we go down different routes and what we would cover. So, Shoaib, say your patient has a sixth nerve palsy.
Oh, that's interesting.
Ooh.
How do you go about explaining that?
So, I don't think this is going to come as much of a shock to the patient because they're obviously going to hopefully be presenting with complaints and symptoms. They're going to know that they've got double vision and it's worse in particular directions of gaze. So you're not going to be kind of coming out of the blue and shocking them with this information. I think I'd sort of, once I've got a good motility and I know what's going on, say to them, I think there's a bit of a problem with one of your nerves that controls the muscle that turns your eye outwards, which is why your eye is not moving. And this means when you look in that direction, because the eyes work together, that one stays there, but this one's turning. That's what's giving you the double vision. I'd explain that it's something that should probably be seen sooner rather than later because the nerve could have stopped working so well for a number of reasons, and some of the more sinister reasons that could be behind it, we want to have investigated a bit with a bit of urgency to it. And I'd explain where I'm going to be referring them to the emergency same day. And I would tell them to get on down there, basically. Just get going.
Off you go.
There's the taxi.
Just devil's advocate.
Oh, and I would tell them not to drive to the appointment.
Cool, but
because they've got diploma.
Devil's advocate. If they ask, how do you know if it's the nerve? What would you say? How can you be so sure? Yeah, how do you know it's the nerve that's causing the issue?
Because every other muscle's working fine. It could be a problem with that muscle. Balance of probability is the nerve controlling the muscle. Because your muscles don't just randomly stop. If your muscle's randomly stopping, I still won't have it looked at. It's the same. It's the same degree of urgency, regardless of what I'm telling them. Is that this is something that's beyond what I can do to help them with, and they need to be seen by a specialist at the hospital, which is where I'm going to send them to.
And what to say, like, so will this all go away? Will it get better? What will they do to treat this?
I'd say it depends entirely on the cause. Sometimes it goes away, sometimes it needs to be treated with prisms in the glasses, but we're still in very, very early stages.
But that's in a scenario where
asymptomatic, not asymptomatic, as in it's just a random nerve palsy that popped up out of nowhere. That's what I'm sort of going on here.
Yeah.
And also, if it's untreatable, that they're going to need to put prisms in, which is a long-term
solution.
Yeah, as in
they can surgically repair it in theory as well.
Yeah, as in I wouldn't necessarily entertain that conversation for too long. I think at that stage,
because you don't know what's causing it.
Getting them to eye casualty is more important. You don't want to.
You know what's causing. You don't know the underlying issue for it.
Yeah, you don't want to sitting there talking about prisms and they've got an aneurysm.
So the light moves it this way.
Yeah.
I think one thing to also note with these kind of conditions is that obviously there are sort of serious health implications of it. So you shouldn't ever be rushing the patient through. Although there is a degree of urgency to get them out to be seen sooner at the eye casualty, there is a degree of making sure the patient is reassured, and the time between you seeing them in your clinic to them getting to the hospital to being finally seen by a consultant is a long time, and the patient sat there worried about sort of, am I going to die from this nerve? You've mentioned aneurysm and you said nerve near the head, so is always is.
But you don't know if it isn't.
You don't want to give
it's not
false hope.
necessarily an
Yeah,
aneurysm,
you don't.
though, is it?
There's a fine line between giving false hope and saying everything's going to be fine, and saying, oh, you're about to have a brain bleed. I think you need to offer some reassurance to give the patient some comfort in that time, whilst also managing expectations of what the potential causes could be.
I think the best way to say it is something along the lines of, we don't know what's causing it, but it's very important that you get it checked, because it could possibly be something a bit more serious.
Or it could be something not as serious.
Yeah,
but we
need to make sure, because
Just be
if
as
it's something
ambiguous as possible.
Yeah, but because you actually don't know what's causing that.
Unless you're going to pull your
all you know is that nerve is not
handheld
working.
MRI out and check.
Yeah, no, of course.
Or
Like
CT
the only thing you know about this patient at the moment is that their sixth nerve is palsy. You don't know what's causing it, so you can only be as detailed as you can, and it is pretty vague on our part. It's just it's not working, and that can be a big deal. So you need to be seen as soon as possible. That's basically
Speaking of eye muscle problems, Mehdi, if somebody came to you with convergence insufficiency,
where did you get that? Just randomly out the bag.
Just randomly out the bag.
Randomly out the bag.
Let me look in my bag.
So Osman, let's switch away from the BV a little bit. What would you do if someone presented with a red eye? Thinking more on the scleritis area.
Okay, yeah.
So you
red eye could be a lot of things, but with the scleritis.
Yeah, like you've done the phenylephrine and it's not blanching.
It's not blanching. Oh, scleritis.
Not episcleritis.
Scleritis. It's not blanching.
It's not blanching.
With your phenylephrine that we all carry.
Yeah. The handy on your keyring, right? just on hand.
I just have it on a wristband.
Just a wristband, just whenever.
I have it installed in an app.
Oh, you got the wireless version. Nice.
So yeah, scleritis is an emergency. So that's really important. So that's one thing I would be communicating to the patient, that you have a condition. It's I go over the anatomy briefly. That the white part of your eye is covered by a clear layer, but it's the white part that's quite inflamed and swollen. That's what's causing the redness. That's what's causing the pain. The change in the color, so on and so forth. And this is something that we really need to treat, and the sooner the better, really. I explained that it's important that they get to the hospital really same day. So that's just so the hospital can hopefully agree with what I think it is. And if it is the same thing, then prescribe steroids or something like that to help reduce inflammation and stop getting worse and risking their eyesight, so on and so forth. The patient's going to be obviously complaining about the photophobia, the pain mainly. So of the issues that they're having, the ones they might be having questions about, the photophobia, the pain, mainly the pain, to be honest, but
the redness,
loss of vision, all of these things, you have to reassure them that these are part of the treatable expectations, that these all will go away, hopefully, and it will get better. The prognosis is good, thankfully. I don't know if I should say thankfully, but because this is one of the conditions that does present with quite severe symptoms, it is something that people tend to get seen quite soon. Other things, floaters, etc., veils in the vision. Sometimes you can find patients have left it for a week or a few weeks, etc. This isn't something people are leaving for a few weeks. So the prognosis is normally quite good. So I just explained to them that it's good that you're here. I know it's painful, but don't worry. It's something that the hospital sees all the time. There's standard treatments for it, and hopefully we'll get them sent up and get them treated ASAP, to be honest. And we'll see them afterwards for the check.
How would you explain it if it was necrotizing? You're never going to get this, but if it was necrotizing, how would you explain it to them? I say never. He's going to get it tomorrow.
Hopefully not. Well, I just explained that, okay, with the reddish part of the eye, you can see there's a black part. That black part, unfortunately, is the stage of the inflammation. It's gotten so bad that it started to permanently damage the tissue. That's something that we really needed to get seen, but something that thankfully we still can see now. So the feeling isn't quite as dramatic as how important it is to be seen. So I just say it's reinforced a bit more because they don't have the same levels of pain, so on and so forth. Reinforce them that this is actually quite advanced. I'm not going to start saying, your eyes dying, the death of tissue cells, etc.
Your eyes going to die, go.
I think words like damage are a bit more.
Yeah, exactly.
Part of your eyes dying, we need to send you off.
Yeah, like, oh, necrosis. So, but
Yeah.
no, I'm not going to be mentioning all that. It's unnecessary to alarm the patient. You
Yeah.
just need to let them know that, of course, tell them their condition because it's their eye. They have a right to
Yeah.
know what's happening to their eye. But pick your words carefully, and I think that's part of it.
Yeah.
And just let them know that it is really important that they get them seen to prevent further damage from happening to the eye.
I think it's also, sorry, I just cut you off. It's also, I think, important for us to realize that a lot of these emergency conditions, bar like retinal detachment, we really can't diagnose because we've just not seen enough of them to know what it actually is. So you can't clinically.
We haven't.
Well, we have, yeah. So we can't actually say it is this and that. We can just say by the signs that I'm seeing, it's important that you're seen as soon as possible so we can get the right treatment for you.
I almost universally say that, this is what I think it is. They may disagree with the hospital.
Yeah.
And normally they like it, that the fact that you're being better safe than sorry.
Exactly.
They like the fact that you're not leaving anything up to chance.
Yeah.
You're not just being like, oh, it's fine, etc.
Yeah.
So they're quite happy for me to say that, I do think it's this. I might be, they may disagree with me up there. Even if something as simple as cataract, I'll say I'm more than happy to send you up. They may disagree with the severity on it. They may not feel it's advanced or mature as I think it is. We see cataracts, multiple times a day. Multiple times a day. We know what a cataract looks like.
Yeah.
And that's not something I feel I need an ophthalmologist to
double check for.
But yeah, I think that's the main word is saying that you're asking for a specialist opinion on the sort of non-emergency. Obviously, with an emergency situation, there's a red eye. It's extremely painful.
Yeah.
We're going to send this. We know what it is. But with certain things, especially with like the sort of obscure retinal lesions, where you're not really sure what's happening, quite often I think patients appreciate the fact that we recognise our limitations and some things do need to be seen at the hospital and we're not going to see them. So they're not massively alarmed by the fact that we're saying, I'm going to send you for a specialist opinion on this and let one of the doctors have a look at this. Because they know that they're going to be in better hands at the hospital than they will be with you. So Mehdi, let's say we've got a 16-year-old who comes in, it's exam season, they're having trouble with reading up close. You do all your tests and you find that they've got convergence insufficiency.
Cool.
They've got a parent with them, let's say, for example, and it's exam season, so obviously we've got that to consider as well. How do you go about explaining that to the parent? How do you go explain that to the child, and what's your management going to be?
So what I would be mentioning, obviously because they're old enough to understand, and probably direct to the actual patient. Mum or dad can be listening on the side if they want to, but I would be going about the way saying that your faraway vision's okay, but when you're looking up close, you're unable to keep the focus, okay, and your eyes, the muscles are a bit too weak and they're pulling away from each other when you're focusing for too long. All right. And I say that that can weaken as we age, but at your age we don't really expect to see this, okay, so we want to exercise those muscles, okay, so they can focus a bit better when you're doing lots of up close work. But because there's exam time coming and the process is a little bit more, you need to be essentially on it, essentially, so you need to be exercising quite frequently. We don't want it to affect your studies, and you can spend that time studying more and focusing on your studies for the time being. So what I would do, I'd prescribe a small prism for concentration.
Okay.
Give them about 2 months recall, depending on when the exam is. And then you have to come in that 2 months, and that prescription will be out 2 months. You're not going to wear it in 2 months' time. You come back, and I will administer some exercise that we can go forward with. And then the exercises would be the pen to nose.
Okay. Treatments aside, because that might differ from practitioner to practitioner. Not everybody would do that.
Personally, I think the clinical way to do it is that, but I would just give them exercises.
That's fine. But treatment aside, the description, I really like the description. One thing that you did explain, but it's the importance of clarifying of the muscle weakness and not a case of just myopia or something like that.
Yeah.
In the beginning, it sounds very much like myopia. You know, far away vision scoop, up close, you struggle a little bit.
That's hyperopia.
Sorry.
The other way, but yeah.
One thing that I find a lot of parents ask me, did you cover whether or not this patient wears glasses or not?
Let's say that it doesn't really matter though, does it?
No, but humour me.
Mild myopia, minus.
So yeah, he wears glasses.
Yeah.
Well, the mother might ask, if he needs to strengthen his muscles, surely he shouldn't be wearing his glasses so he can, work his eyes a little bit more.
And then you'd be like, well, the glasses that he wears actually promotes this if they're myopic.
How does that work? I thought you have to wear glasses.
Because the way the eye works is that, especially with his prescription, it promotes the eye to work a little bit harder. And therefore, when you're putting this in front, when he works up close, it's pressuring the eye to pull the eyes together, pull the muscles together, so he can focus up close. I don't know. It's a pretty wishy-washy explanation.
Would you add anything else to that?
I would just really illustrate the physiology of it. I say there's the near triad, and
yes,
I don't want to go too far.
Yeah, we're
that's the thing. I'm trying to explain that without explaining
it. Of course,
it.
yeah. I wouldn't go as far as to say the near triad. I'd say wearing glasses and not wearing glasses in this case isn't a case of his eyes working harder or working weaker. If he's you're taking off your glasses doesn't mean you're going to be working harder. It's not hyperopia, it's myopia. So the lack of glasses just makes things blurred, but the glasses on makes things clear. So the glasses aren't going to be affecting the eye muscles in that way. What's going to be happening is there's an entirely separate muscle, which is the eye movement, which is following the pen towards your nose, and that muscle's weak. That's got nothing to do with his prescription. It's entirely about where he's focusing at what distance he's looking at.
I've actually had a few convergent insufficiencies.
Insufficiencies.
I can't say it.
Fishy.
Convergence
Insufficiencies.
insufficiencies. That's what.
Salmons or tunas or which
Fishiness.
one?
Convergence insufficiency. I've had a few patients with that condition. So I've always dealt with them with the whole pen to nose thing. I've always called them back, and I actually see it work as well.
Fantastic. That's always good to see.
It's always good to see when you say something and it turns out to be true.
And the patient actually does the exercise.
Yeah, exactly.
I'm not making this up.
Yeah,
I'm not know that myself.
Wait, you're legit. Same with dry hairs, actually.
I follow up with mine.
Oh, really? Oh, yes. I'm a locum, so I send it to you guys.
He's like, come to the other store.
Yeah, just go anywhere. They'll know what's going on.
In 2 months, I'll be in a different city, but sure. Okay, thanks for joining us. Hopefully you might learn something. But we'll see you next time.
Just remember, it's not clinical advice.
It's never clinical advice.
Never clinical advice.